Imagine this. You're at a party, music's thumping, someone hands around a drink, maybe something else. You're not really into that stuff, but someone you know, a friend of a friend, takes a pill they swear is just something to take the edge off. An hour later, they're on the floor, not moving, not breathing. Someone screams, people freeze. Someone says, call 911. You're the only one who does. The paramedics show up. One of them pulls out a little orange box, sprays something into their nose, and waits. Seconds pass. That feels like years. And finally, they take a breath. Or imagine a different scene. A man in his 60s is recovering from back surgery. His doctor gives him something for the pain. It works. Too well. He starts needing more to just get the same relief. Weeks later, he's not himself. Sweating, anxious, missing work. He's out of pills, and he's desperate. He's not trying to get high. He's just trying to feel normal again. These are not rare stories. They're not urban legends. They're real. And they're happening in every city, town, and suburb in North America. Today, we're talking about opioids, where they came from, how they work, why fentanyl's changed everything, and what Narcan has to do with saving lives. There's a lot of misinformation out there, and even more stigma. By the end of this episode, you'll know what's true, what's not, and what we can do about it. Welcome to Not Another Medical Podcast. The views and opinions expressed in this podcast are those of the hosts and guests, do not reflect the official policies or positions of any affiliated institutions or organizations. This podcast is for informational, educational, and entertainment purposes only, and it is not intended to provide medical advice, diagnosis, or treatment. Listeners should consult their own healthcare professionals for any medical concerns.
I'm Josh Levitz, an internal medicine physician.
I'm James Jung, a general surgeon.
And I'm Brodie Nolan, an emergency doctor. And this is Not Another Medical Podcast.
You guys are so good looking.
Oh, thank you.
Good looking bunch. The listeners can't see us, but they just have to trust us.
Yeah.
Definitely like a solid 8.2 out of 10 for
8.2.
the average in the room here.
Oh.
Oh, wow.
My wife gave me 5.3 at best, so this is a real upgrade.
Oh,
Oh,
you're welcome there. But
you're
Josh,
welcome.
your voice is like a 9, 100%. You've got that.
Thank you.
You've got a face for magazines and a voice for radio there. Oh, best of both worlds.
What's a magazine?
And
I think we made that
beard
joke.
of the gods.
You guys done anything recently? Something fun with the
It's
kids?
it's my youngest birthday tomorrow. She turns 3.
cool.
Happy birthday.
So yesterday we went to Center Island, which for those not familiar with Toronto, Toronto has islands across from it there. And one of them has this little theme park, amusement park. And so we went there yesterday, and honestly, it was like a blast. The trick was we went late in the afternoon. So most people that already had young kids were kind of leaving and packing up. And so there's no lineups for rides. It was pretty sweet. It was good times. Yeah.
Cool. Center Island hack right there.
Mm-hmm. Yeah.
That is a nice spot. A little ferry, 15-minute ferry from downtown Toronto. Of course, you have to spend 60 minutes to get to downtown Toronto.
Yeah, I was going to say, the worst part was if you're driving to and from.
It's worse. It's worse now, James, since you left. It's about 2 hours.
Yeah. And then about 40 minutes finding parking. Then we missed the ferry, so we water taxied, which actually wasn't the worst thing. Yeah. And yeah. Anyways. And then the nice thing was on the way back, we just had dinner on the island looking back at the city on the water there. It was
that's beautiful.
quite nice. You see all the airplanes and stuff taken out. It
It
was nice. Memorable
Nice
for us,
skyline.
not for my
Yeah.
now 3-year-old, because she won't have any recollection of it.
You never know.
Well, that's why we took 10,000 photos of
Oh, man.
of them growing up, right? This is how Apple makes money. They keep asking for more iClouds.
The time and effort to make memories that they just don't have the capacity to keep long term is quite challenging.
Yeah, exactly.
I can't keep memories either, so works for me too.
Sure, I shouldn't. Yeah, I shouldn't pinpoint it just on the little ones. Yeah,
No,
I also
absolutely
sometimes need photos to remind me where I've been and what I did.
I mean, memory. If you want to do something cool, read about memory and how wrong our memories are just on a regular basis.
Oh yeah, yeah. And I think we trick our minds to remember certain things and exaggerate certain findings, and it's almost like we're fabricating in our own mind. It's a very fascinating area of science.
We're deep faking ourselves?
Yeah.
So,
So I swear I was there.
Yeah.
my
You can't
wife
prove it.
100%
I can.
suffers from like the worst memory recall. If you have an example of this, so we will go to a new restaurant, eat something, and it'd be like, this is like the best meal, most amazing thing, like, was awesome. And then every time, like, never fails, the second time we go back to that restaurant, it's awful, never is good. Like, there's just there's something about that, the first time experiencing something, or first time having like a certain combination of food or flavors that just never reproduce the second time.
But well, it depends on, I think it depends on interval too, right? Like, so the restaurants, it's hard to be consistently good, right? The restaurants that stay for 15, 20 years, like these are like really good restaurants. They can, that have
McDonald's.
like great flavors and all. Yeah, exactly. Consistency is key.
I don't know if I've ever had a consistent Big Mac, Josh, or Whopper.
Oh, come on. They're nothing but consistent.
Well,
You know what you're getting.
But it's also like, the memory too. Like, think about why you go to McDonald's. It's either you're,
Drunk.
a little too drunk or too tired. You're
After my night
post-call.
Yeah.
Yep.
And,
Or
and
now
then,
because your kid wants a Happy Meal.
yeah.
We've got toys.
And you eat a cardboard, you're like, oh, this is the best thing ever. Consistently good.
James, that actually is the box that you're eating. Please go to the burger.
Yeah. Oh man.
It's amazing.
Wait, I can tie this together. Okay, so
Yes.
just like that, the first time you try something,
hold on.
you're always
Segue.
Well, here we go.
okay. I'm gonna bring it in.
No
Bring it in,
pressure.
guys. So just like restaurants, the first time you go is always the best. People say the same about drugs. The first time that you get high, that was the best, and they're always chasing it. Maybe not. Wow, stretch. Swing and a miss.
James, out of 10, what would you give that segue?
I think it's a cut. We'll edit this out.
You're not even giving it a number, just a cut.
No, it's let's not waste the the videotape.
10 for the effort, 1 for the content.
Let's not waste the iCloud.
Those megabytes weren't worth it. All right, sorry team, let you guys down. Someone else take it home.
Yeah.
Let's talk
No,
about
I mean,
opioids. Boom.
Yes.
There we go. Straight to it.
But there's components of memory and memory loss. At least well, there's something there.
Guys,
but
we just got to accept our strengths and our weaknesses. Segueing is not a
Yes.
strength.
It certainly is not our strength. But
No.
Lucky for our listeners, we have great
Editing software.
episode about that too. But we also have a great content, talking about a really, a topic that affects a lot of people and maybe some of the folks that you know. So, take it away, Brodie. Like, this is your topic, and this is something that, you see quite often in an emergency room. So love to hear kind of your perspective, your high level kind of overview of why this is such an important topic.
Yeah, for sure. I think probably most people in their life will probably get exposed or be given opiates at some point for something, right? Whether it's surgery or going for pain or dental procedures or, there's all sorts of reasons why people are given them. And so I think it's really important. They're commonly prescribed. They're talked about quite a bit right now in the media as well. I don't think it's a surprise to anyone hearing about things like the opioid crisis and, what is that and what does that mean? Or we're also seeing more and more things like Narcan being suggested or recommended for bystanders or carrying Narcan kits, for example. So I thought that was kind of something that would be kind of interesting to touch on. Definitely it's quite relatable and quite out there. So I thought maybe starting off with, what are opioids? How do they work? Like where they come from? Yeah. So, opioids they're a class of drugs or medication, and they act on the opioid receptors, hence why they're called opioids. And in addition to relieving pain, they produce euphoria, also drowsiness, and at high doses, they can also slow your breathing or actually cause you to stop breathing, which is how people can overdose and can die. There's a lot of reasons why we use these within medicine. Most common would be pain control. So again, we see this a lot in people that are having surgery. So James, I'm sure a lot of patients on your ward might be having them. They might be dealing with long-term pain conditions, so chronic pain, or patients that have, pain from cancer or recovering after trauma or injury. Certainly end-of-life care, again, something that we see a lot of. And then there's some of the more subtle uses that we see in medicine that probably aren't, commonly advertised, I guess. So, a lot of people take cough medications, and a lot of those cough medications actually contain codeine, which the body transitions into morphine eventually. And so a lot of the reason why it works as a cough suppressant is really because it just reduces your drive to breathe, which also then reduces your drive to cough, where it kind of helps.
Yeah.
And the other reason
it just
too
blunts everything, right?
And honestly, probably a bunch of listeners are like, what? And they just stopped using cough syrup mid-swallow.
Well, not all. I think we have to be careful. Not all syrups. But you got to look at, everybody has to look at the labels and really understand what they're taking. And, those, should be prescription only.
Yeah. It's a good point, James. Yeah, these ones probably aren't kind of over the counter. It should be ones that you should ask your doctor or the pharmacist for, just to kind of make sure, especially if these are things that you're going to maybe giving to other people besides yourself, right? Like all of a sudden you've got a child that's got a cough. Like, I had this cough medicine that worked for me, and I give them a dose, right? If you don't know that it's in there.
Yeah. Never share drugs, right? Like, that's, I think, very important thing. But Brodie, I want to kind of go back a little bit, So you talked about opioid receptors. So these are the protein complexes that are in the central nervous system, the brain and the spinal cord. And, these are medications, these are molecules that are broken down and then get absorbed, and then they target sometimes more broad receptors. And then the downstream effects from the receptors take those actions that, and then we try to extract we try to understand what they are, and we make medications or drugs to target those receptors. So here it's really the opioid receptors in brain and spinal cord. And I think that's really important because a lot of it, like we said, is really blunting some of the responses, in the CNS.
Yeah, perfect. Thanks for highlighting that. And maybe to add on to that, in addition to blunting those pain responses, that drive to breathe responses, the other thing they do is they release dopamine, which is a neurotransmitter, a hormone in the body that it gives us that feeling of euphoria, of feeling good, right? And that's why
satisfaction,
exercise releases dopamine. It's that kind of reward system. And that's how
it's a happy hormone, right? It's a
the happiest of the hormones.
There's an argument there. I can find some other happy ones.
That's our next one. We're going to have
a hormone battle.
And this becomes really important, when we talk about opioid addiction. I think so. The satisfaction, the reward in this pathway is what feeds into this type of medications being quite addictive, just like cigarettes or whatnot, right? Other types of, or alcohol or other types of drugs.
Yeah, guys, something really important here. It's been a long week for me. My brain is pretty fried, and I love the conversation you guys just had, but I had a lot of trouble following it. So thank you for taking that part on.
Yeah. We're here for you. We're your dopamine.
Yeah. Oh, that should be our shirt. I'm your dopamine.
Yeah, that's right.
I like that.
This podcast release is my dopamine.
There you go.
There you go.
Get addicted.
There you go.
Brodie, I think just to go back, you were talking about some of the things that contain opioids, and I think maybe missed one over-the-counter one that a lot of people probably don't know is an opioid. Did you talk about loperamide? Is the generic name, but the brand name is 222
Imodium. Yeah,
Boom.
That's right. So
Mind
all those
blown.
commercials about not releasing your diarrhea with your friends in hot tubs, it's mostly I remember. I didn't make that up, right? I feel like those were like legitimate commercials. Okay.
I don't know, memory, man. Yeah.
First time I saw it was the best. Anti-diarrhea medications, loperamide also is an opiate or works on opioid receptors, which I think would maybe go back to the list of effects. I don't think I talked about GI effects, but it slows, your GI system. So on the extreme side of that would be constipation. Of course, if you have diarrhea, the benefit of stopping that, which is how it then works as an antidiarrheal or kind of, anti-motility agent like loperamide.
Yeah, I was going to say there are people who actually tried to overdose or tried to get high off Imodium. And I think there were some public service announcements over time, but it's a thing.
That never made the commercials.
Yeah.
No.
I think it's important to highlight, though, that the loperamide medication is designed to target opioid receptor in the gut and not necessarily in the central nervous system, but sometimes there may be some cross binding to the CNS. I see this often when patients take opioids because of pain control. They come back with a certain degree of constipation, whether it's transient or long-term. And, the pain medications that are opioid also target opioid receptors in the gut. And, the effect of that is it slows down the gut motility or transit of stool. And that's what causes constipation. So, the opioid receptor downstream effect, there are a variety of things, not only in the CNS.
Yeah, it's a great point, James. And I mean, maybe, Josh and James, you both prescribe, I'm sure, opiates routinely in your practice, again, for the different things we were talking about earlier. But maybe along the lines of that, like if you are prescribing someone opiates for the first time, for a short course, for whatever it happens to be that they need it for, are you doing any of that? Like, are you prescribing anything else to help with motility, or do you recommend anything?
Yes. Very important that we follow with multimodal pain management. So we do a lot to try to minimize opioid use in post-operative phase. So, obviously surgery causes pain, and the patients during surgery are taking opioids, whether they know it or not, because, the general anesthesia and the concoction of medications that are within during the surgery also includes a lot of the opioid medications like remifentanil, the short-acting form of opioids, and that is to blunt the pain mechanisms. You certainly don't want to have, physiologic stress related to pain during the operation. So they take a lot of those things.
If you're operating on me, I want zero pain.
Yeah. Like, so,
sure, the
medications are designed to make you pain-free and also to not remember any of those and to reduce anxiety. So those are kind of the anesthetics that are designed to do. So, but part of that concoction is opioid. So after the surgery, we try to reduce the amount of opioids because of the negative consequences. And to do that, we use a lot of local anesthetics to blunt the areas of incisions and sometimes, perform regional blocks to anesthetize the nervous system in that area. And then importantly, when they go home, I always tell them to take Tylenol, Advil if they can, every certain number of hours for at least 3 to 4 days. And then if they have breakthrough pains, then we give them, limited number of tablets of opioids so that they could take it to treat the breakthrough pain. So that hopefully, and that has shown that it reduces the amount of opioids that they could take.
We have a ton to talk about, but I think really important to highlight that North America, we are not as conservative with opioids as other parts of the world. We prescribe a lot here, for better or for worse. But if you look at prescribing practices, not just post-op surgery, but for many things compared to like Europe, say Canada and the US versus Europe, it is vastly different. And I don't personally know the reasons behind all that. I'm sure marketing was a huge thing in North America, but really important to know.
Yeah. That's a really good point. Yeah. Just to add to one point, throughout my kind of training and through networking, I met some European surgeons who would send patients as part of the pain control regimen, non-opioid pain medications, and also go drink a tea. Like, as like part of like relaxing, relax and listen to like classical music and, drink a hot tea as like pain regimen.
And is it important the type of tea and the composer of the music? Do we go into details, or we should just skip that?
I think that's, depending on what you're looking for, but I think there's a good randomized controlled trial waiting to happen.
Yeah.
Heavy metal versus classical jazz.
Mozart versus Metallica.
Yeah, that's right.
Yes. Yeah. I mean, it's interesting then to reflect a little bit on maybe the origins or history of opiates, right? And how that goes. So,
Hold on. That was a good segue. We talked about prescribing practices. I am impressed. And I'm also breaking up the flow, but I'm still impressed.
Yeah. I will allow you to break that up for that compliment. So thank you, Josh. I accept.
As you were.
Now we'll continue on.
World-class journalism. Podcasting skills.
So, opiates come from the opium poppy, which has been around for forever, for the most part. So I guess for the purposes of timelines and this podcast anyways. Fun fact, in some ancient civilizations, it was known as the joy plant. So again, the use of, plants, herbs, spices for, creating euphoria. Not new to humans or really animals or anything like that.
Everybody knew.
Everyone knew. But it's around the 1800s that we actually isolated morphine. For a long time, I think morphine was mostly prescribed for kind of end-of-life, chronic, like cancer type of pain. It was actually in almost kind of the turn of the 1900s, but heroin then was synthesized and created initially as a cough suppressant. So, I'd say we've come a long way from there as far as prescribing practices.
Have we though? Have we, Brodie?
Maybe not. Based on what we're talking about, it works.
Yeah.
And then really in the 20th century, we saw all the synthetics opiates. So these are going to be things like hydromorphone or Dilaudid or OxyContin, oxycodone, fentanyl. These are the ones that we really kind of see coming up over the last kind of 100 years or so, or 50 years. And Josh and James, this might resonate with you guys, but I think when we were going through training, we were kind of at the tail end of this time in medicine where there's a big focus on pain. Right. And I remember going and a lot of our lecture at the time was, pain's a fifth vital sign. We're under treating pain. Everything is using pain scales and everyone should have a 0 out of 10 pain. And that was really like almost every lecture that we had about pain and management, right, was doing that. And I think that it reflected probably a big push from the pharmaceutical side, but really this practice that we then saw of really over prescribing opioids, Josh, as you were talking about there.
Yeah. And it's funny because there's a lot of movies. This has been publicized now, documentaries, everything. And you see these pain scales you're talking about, Brodie, that we learned about. And I forgot about that, where like the worst pain, it's based on your facial characteristics. So if you're grimacing and your face is red, that was a pain scale of whatever, 10. And if you're super happy and good, probably because you got opioids, it's a 0. And we learned about these things. And that's originally from the drug companies. So it is wild how it's just evolved and actually how recent this was.
So yeah, when we were in medical school, there was this transition point, I think. I think our medical school being one of the more cutting edge academic medical schools really accepted and acknowledged this mistake and moved on pretty quickly to disallow these things. But you could imagine this being kind of influence in the course of other, even younger generations of doctors training, right?
And I think I saw that too, is really even people that came out and finished 5 or 10 years before us, there's a much longer transition to maintain prescribing high doses of opioids for quite long. And I think it was because they kind of, again, as we were going through, all of a sudden we kind of realized that I think the onset of what we call now the opioid epidemic, right? But habits can be hard to break, right? And if you think you're doing the best because that's the training you had at the time. If any listeners are interested, there's a bunch of great books, I'm sure podcasts and other things out there. I will do a plug for Empire Pain, phenomenal book if anyone's interested. And maybe James, just to highlight, because you said Purdue Pharma, again, that's the company that, first really marketed oxycodone, right? And I think really was quite aggressive in their targeting practices for undertreating pain.
Yeah. More in terms of like, paying off prescribers and creating a milieu in which overprescribing was encouraged, despite regardless of patients' needs. And that really had resulted in a significant number of patients who became dependent on narcotics. So, certainly important factor. And I think the strategy of the pain as the vital sign, right? It's a really shrewd one from pharmaceutical companies' perspective. And I've been telling this to my patients who are undergoing surgery. Of course, they're worried about pain afterwards. And I always tell them that pain is expected. You're undergoing a major operation. Pain is expected. You're going to have pain, but we're going to help you get through that. And that may require opioid, but having the pain level go to zero by providing a lot of narcotics is not the best practice for patients. I think so.
Yeah.
The pendulum has swung back to having acceptance that some level of pain is expected, but we want them to have high functioning and recovery where they could walk around and do all these things to get them better.
Totally. I mean, I think, pain scales being a perfect example. Like, I've stopped asking patients what their pain is on a pain scale because, one, we know it's quite subjective, right? In the same way that I think Josh is like a 8 out of 10 hotness. Someone else might say he's a 7. Some might say he's a 10.
Most people would say 9 to 10. Yeah. I mean, most people, just like they say on the pain scale, they say 13 out of 10 for my level of good lookery.
If I know it's subjective.
So Brodie's more generous than his wife is.
Hey-o. Oh, man, you're bringing me back to dead animal guy here. He was a 10.
That was a previous episode, listeners who skipped that one.
No, but I think pain scales or rating of pain will still probably be there just for patients you'll probably ask by providers, how would you rate your pain 0 to 10? But for me, I've changed the question now to, do you want anything? Like, are you in pain and do you want anything for it? As opposed to, I think before it was like, well, their pain's a 4 out of 10. It's not a 0. We need to give them something, and kind of having it that way. So I think, James, totally to your point. I mean, depending on what they're in the hospital for, pain might be expected as a part of their course. And it kind of depends on their individual preference and tolerance. And I'm finding more and more, people are very aware of opioids and the challenges and the addiction potential. And they're also sometimes like, I don't want anything like that. So they're okay to tolerate that higher pain, knowing that other things would carry risks.
Let me jump in. I may derail this and kind of take us off script, which is what we do best.
We had a script.
Yeah.
But go ahead, Josh.
Yeah, thank you. I've lost my train of thought. No, that was awesome. I think the whole question of should opioids be prescribed, and there's obviously an easy answer, right, which is yes, but there is so much stigma that's associated with them. And Brodie, I think you mentioned it. The pendulum has swung very far, where like Purdue times, it was obviously way too many opioids. We didn't have the facts. Now, for many reasons, I would argue that we've swung the other way, where we often aim not to prescribe opioids when sometimes they're probably needed. And people get stigmatized. People who are on them feel like they are less than. And I'm going to put it out there now. Some people need opioids, and some people, unfortunately, need opioids for life. And obviously, you have to work with your doctors to try to wean if you can. There's evidence to say some people can't and shouldn't. So putting it out there, you're not a bad person. It's not a bad thing to be on them if you truly need them.
Yeah, it's a very hard, as prescribers and healthcare providers, there is no objective measure of your pain.
Yeah.
Right? I mean, pain is a subjective thing to begin with, but also we don't have a tool that can reliably measure the pain that a patient is experiencing that will say, okay, this person requires opioid. So that's the hard part for us. Our management of pain depends on our experiences, our training, external influences, unfortunately, as well, right? I remember when I was at the early phase of my training, we used to prescribe 30 tablets of oxycodone after gallbladder surgery.
Yep.
Like routinely.
Or anything, just leaving the hospital with any
pain.
Yeah. That would be very normal. Seriously, that'd be so normal.
Yeah, like 30 tablets.
Here's a dozen Percocets.
And now it's swung down to like something like 5 tabs. And I think currently we're seeing 7 to maybe 8, depending on, your practice again. Again, not being hung up on the numbers, but you could see, these are the same operations that we're doing. So in terms of objective level of invasiveness of the surgery, it's been the same in the last 20 years. But our patterns of prescription have swung depending on the external influences and the training. So I think it's always been very difficult. It's hard to personalize this. Some patients require opioids, some patients do not. It's hard to personalize this. And I'm hoping that with this medicine being on the cutting edge, we're finding more and more on how to identify patients who require stronger pain management than others. And I think that should be the way to do it.
It's a good point just to highlight the main risks with opiates. Right? I think we've kind of talked around them a little bit, but really there's three main risks I think of. So one is tolerance. Right? So these are patients that have been on opiates for a long time, probably not for 3 or 4 days post-op, but weeks to months, and they're going to need higher doses to continue to manage their pain. Or if they have pain on top of that, they again might need higher doses than would traditionally be required. The second is dependent. So these are patients and that would actually develop symptoms of withdrawal. So sweating, tremor, they feel nauseous, vomiting, kind of flu-like symptoms as well, will be kind of symptoms of withdrawal. And then really the third risk for opiates being addiction, which again is really where you kind of lose control over your use, or it's affecting your life, your work, things like that.
I think the other one, the fourth one here that I think we're going to talk about, which is important, is overdose. Yeah. So the overdose, of course, I think it's important to tease the addiction and overdose apart, right? Because addiction is a different thing. If you are addicted to opioid, you have a higher chance of overdosing on the opioid. But there is a chance that you could still overdose even if you're opioid naive, you're new users of the opioids and so forth. And probably you have higher chance of overdosing if you're unaware of what you're taking. So I think that's an important distinction that I want the listeners to see.
Oh, totally. So not a segue, but this brings me back a little bit. So if you guys remember in med school, I'd work at night at these raves.
Don't remember. No memory of that.
But downtown Toronto.
That I remember because that's yeah. Some of those stories I still remember.
Yeah. So what are now some very high-end luxury furniture stores at one point with giant rave and concert halls. And so I would medic there with the goal of trying to keep people there and not going to hospital. The point is, what we were doing when I was doing that, a lot of the drugs were still relatively pure. So if you were taking ketamine, it was ketamine. If you were taking ecstasy or MDMA, it was ecstasy or MDMA. If you're taking crystal meth, it was crystal meth. And James, to your point now, there's so many things mixed with everything that it's really hard. There's a lot of stories that come out of people taking a single pill of something at a party that they thought or was told to them that it was ecstasy or MDMA, but it happened to be laced with fentanyl or another opioid narcotic. And then, they overdosed in their first time, not knowing that they even took a narcotic, right? And I think that's the kind of the scary thing right now, really, with the supply and the drugs right now that we're seeing. Even right now in Toronto, a lot of the patients that we see that are coming in with a quote unquote fentanyl overdose are staying sedated and obtunded or requiring very high doses of Narcan, which we'll talk about in a minute, to try to reverse the opiates. But it's because it's mixed in with all of these other sedatives that stay in their system for a day. And so it's really challenging sometimes, just because when you're talking about getting drugs from out of hospital, the supplies are so tainted and it's hard to know what you're actually taking.
So what do you do, Brodie, when they come into the emerge and probably a drug overdose, but you don't really know what? How do you manage that?
Yeah, so let's talk about a presumed fentanyl overdose. And so fentanyl is a very potent opioid. Again, we use it in hospital quite often for pain. The reason why, when I'm in the emergency department, for example, why I would give fentanyl would be I want someone to have pain relief immediately. It kicks in within about a minute. So someone has a obviously broken bone and sticking out. I want them to have pain relief now, not in 20 or 30 minutes from now. I would choose something like fentanyl that would be fast on and wears off quickly. So there's a role for it. So signs that we see with opiate overdoses based on, again,
so let's stay with the fentanyl for a little bit, because I think understanding what fentanyl is really important for the listeners as well. So Fentanyl, you said, synthetic opioid, very potent.
Mhm.
This is like
Yeah,
50 to 100 times
dosing
more.
is like micrograms,
Yeah.
like tiny
Right.
amounts
These
that
are
are there.
tiny, tiny ones.
Yeah.
Yeah.
Obviously, the supply that we have in hospital is regulated, so we know it's
Yes.
just fentanyl that's being given.
Exactly. Yeah.
And we tend
So
to
very
give
important.
it through intravenous
Yeah.
or through an IV.
Yeah. So fentanyl is a medication that, has been FDA approved, Health Canada approved, to be used for like anesthesia, like for operation, for cancer, pain.
Patients that have
We
breathing
sometimes use it
tubes.
for we sometimes use it to help with and like procedures, like like where it's painful, right? So fentanyl is synonymous with like illegal drugs these days, but fentanyl is absolutely not a legal drug in regulated setting.
I would say that's probably a conversation I have on every single one of my trauma shifts where I ask the nurses to give fentanyl and the patients are always like, no, what?
What?
And then they're like, no, it's okay.
Yeah.
You're giving me
we're
what?
monitoring you carefully. We know what we're giving and how much we're giving you.
And in our world, like preferring hydromorphone or morphine or one of these other, like it's all the same in our world, just they work differently. And they're okay in the right hands.
Yeah. And the important thing about fentanyl is it's short acting.
Exactly.
Fentanyl, remifentanil, these are short actings. That's important because we want that effects to be present for only a short amount of time, specifically when it's a procedure or these specific types. So I think these are actually really important drugs for a lot of the invasive procedures that we do, and absolute requirement for patients who are undergoing these invasive procedures.
Yep, totally. Yeah, thank you for that, James. Yeah. So what does a fentanyl overdose look like when they come into the emergency department? There's really a couple of three telltale signs, I think. So one is we would say they have a decreased level of consciousness or they're unconscious, right? They're not responding. They're not answering questions. The second thing is we would see pinpoint pupils. So we'd very, very, very small pupils. And the third thing is usually they have a very slow respiratory rate or breathing effort, or they're not breathing at all, and someone is helping to breathe for them, being the paramedics often assisting with their breathing that way. But those are kind of the three telltale signs of an opiate overdose that we tend to see. So if that comes in, there's this medication. It's called Narcan or naloxone. And it essentially is a medication that reverses opioids from the receptors. So it kind of knocks off those opioids from the opioid receptors, which therefore now you would no longer have the effects of that opioid. So then you would see an improvement in their level of consciousness, improvement in their breathing, their respiratory rate, and usually their pupils would get bigger as well as a result of that.
Brodie, do you ever call it the EpiPen of opioids?
Oh man, I feel so dated now with the med students that are coming through. But every time I try to describe what giving Narcan looks like to someone who's never seen it before, I talk about Pulp Fiction and how when Uma Thurman gets like the epinephrine injection to the heart. That's like, that's it. They go from like being like a table, like they're not responsive. You could like, hit them as hard as you want. They're not going to move. I don't hit my patients. But like, that's the level
anymore.
Of like,
you got reprimanded for that one. You learned.
Yeah. But they go from that to like being like up and awake and running, and it's
I think it is important. It is important to note, listeners, Narcan does not get injected into the heart.
Yeah,
you did it wrong.
Yes, please don't. The needle shouldn't be that big.
Oops.
But so maybe to wrap up a little bit on the overdose perspective, people that die from opiate overdoses primarily die from respiratory suppression or depression. So they're not breathing enough. That actually causes them to become more obtunded. Their carbon dioxide levels rise in their body. They become more acidotic, and then their body kind of slowly breaks down that way because their oxygen levels drop. And as we talked about in some other episodes, again, if you don't have adequate oxygen for more than 4 minutes, then you start seeing effects like brain death. It affects your heart. You'll have abnormal heart rhythms and then essentially die from that. So that's what people that die from opiate overdoses usually die from a breathing problem primarily. Respiratory, not breathing. Yeah.
So for example, if you don't have opioids on and you're trying to hold your breath, there's so much drive in your system to say, hey, stupid, like you got to start breathing. Like, you'll do anything to start breathing, right? here, because again, the opioid receptors in the central nervous system are occupied by the opioid medications, that it's so blunted, and you have no kind of drive to override this and start breathing. So that's the issue. And then the Narcan is the medication, as Brodie said, it kicks the opioid out of the opioid receptor so that, the downstream effects of that opioid are reversed.
Yeah. And so, why is this important? Well, again, if we think about, we've talked about this, but often you hear like time is brain, time is heart, yada, yada. So, in an opiate overdose, again, time is both of those things, right? The longer that they are not breathing, the more likely they'll have, can run into issues with their oxygen levels being too low, or really kind of dying from that. So time is of the essence with it. So the sooner you can give Narcan to someone to help with that, the better. The other thing is sometimes these people have already gotten to the point that they've lost their pulse. So sometimes these are people that you're also doing things like CPR at the same time. And Narcan comes in a couple of different forms, and a lot of certainly with us in Ontario, you can just go to the pharmacy and request a Narcan kit, which is kind of great. Typically, those kits that you would get from the pharmacy will be a nasal spray, so you would just put a plunger up the nose and spray it. Sometimes there's kind of 2 doses you would give, and again, it acts fast enough you'd be able to reverse someone from it. They also have some kits that you would go and you would actually give an intravenous injection, or if paramedics are responding, or in the hospital, someone comes in, we're usually putting an IV in these patients and giving the Narcan through an IV injection.
So just very quickly, if you're not in the hospital and you do have to give Narcan for whatever reason, next steps, I assume, calling EMS right away.
Yeah, so I would be doing the normal stuff you do for CPR. So check if they're breathing, or if you're trained looking for a pulse. If they're not breathing, you start chest compressions. Ask if there's a defibrillator around. Call 911. And then I think if you have any suspicion for this being an overdose, then giving Narcan is also safe. The nice thing is, because again, Narcan works by just bumping opiates off the opioid receptor, there's not a lot of really no side effects to it. If there's no opiates on board, there's nothing to knock off the receptors. It doesn't do anything. So it's kind of a nice thing that if you can give it, it takes that off the table as far as being a reason why, things have happened. But there's not really any downsides to giving it, if that's the case.
Yeah. I think that's important. This is not harmful to give to a patient who is unresponsive and down, and you're suspecting opioid overdose. But if it is opioid overdose, this is life-saving. And this is available over the counter in the nasal spray. I just checked. You can get it from like Amazon Prime as well.
Can you?
So, this is a life-saving medication. If you're a user of opioids, this is definitely something that you should be carrying.
This is the wild world we live in. You can get these life-saving medications on Amazon. Like, that is a wonderful thing, but that is so weird.
It's true. Also, you could get like garden stones from Amazon for like 600 pounds
now
of
I
them.
have questions.
I'm trying to order some of those.
So do I. Guys, we are immediately switching gears and talking about garden stones. What are they? Why would you need 600 pounds? And James, why do you know this?
Oh, man.
Go.
Well, we have a backyard, and we need some
you live
stones for
place of
drainage. I only have a small car. I don't have like a big pickup truck. Or even if you have a big pickup truck, these are a lot of stones.
That Amazon
So I've been looking for ways
delivery
to
driver
kind of
must hate you.
hate. Yeah, I haven't done it because
Do you buy them then return them just to piss the guy off?
I was thinking to myself,
Man.
they know where I live. Do I want to do this to these guys?
Yeah, exactly. You're getting stoned on your roof.
Yeah, that's right. Yeah, we got sidetracked here, but Narcan, very, very crucial. Garden stones, not crucial.
Not another medical podcast. We cover everything from opiates to Narcan to garden stone.
That's right.
Saving lives to saving gardens.
Oh, man.
That's right. So, Brodie, let's touch briefly on addiction. This is a little different, but addiction is probably an episode in its own. But let's talk about opioid addiction just a little bit, and how somebody who has addiction can address these issues.
I think that the biggest thing is, again, to try to remove the stigma around addiction, which I know is challenging. I think probably a lot of our listeners may have firsthand experience with a loved one who has some degree of addiction. It's just so common right now, especially with opiates. Maybe not, but I think unfortunately, especially with opiates, this is something that a lot of people got into because of the medical system. Right? Again, it was kind of they were prescribed it by a doctor to start, and then kind of they went through those things, like, again, having some tolerance and developing some dependence on it, right? One last segue on this, then I'll continue. So, oxycodone, for example, right? Again, big, highly marketed drug from Purdue. When it first came out, the half-life, or sorry, the dosing that was recommended was every 12 hours. But what we know about the drug is, for most people, it only lasts 8 hours, 8 to 10. And so that meant that twice a day, people were going through active withdrawal. And so when they started having those symptoms, they were then rapidly upped on their dose, but they still weren't taking it frequently enough to do it because the drug just didn't last that long. And so you see that we can very quickly develop that tolerance and dependence. Again, withdrawal, it's not a pleasant thing to go through. So, addiction is challenging and complex. I think because of where we are right now in society, there's been a lot of great work at trying to improve access to treatment centers or addiction clinics, for example. So, you might be in a place that they might have a safer supply of drugs. So maybe then at least that what you're getting is clean fentanyl or hydromorphone or certain narcotics or different drugs, as opposed to often what's the illicit drugs on the street that are there. Yeah, there's drugs that help with reducing cravings. So things like methadone, Suboxone is another one that we see again. So there's lots of different ways that are out there. I think the hardest thing for addictions, you need to make the person themselves needs to be in a place that they're ready to make some kind of commitment and decisions to go forward with some of those. And that can be hard and can change back and forth. So, obviously, if someone that's there, or kind of in that sort of place, or if you're in that place, see what resources are available. These are things that I have no problem. Especially at my hospital, we have a lot of people coming in with addictions and requesting support with addictions, and we're blessed that we've got a great addictions team and clinic and stuff we can set people up with. But this would be something very, very reasonable to ask your doctor about what different options are.
Yeah. And I'll comment, because I'm very passionate about the substance use disorders, addictions. They're called different things now. The medications we use for substance use disorders, whether it's opioids or otherwise, they are saving lives more than ever. And the evidence for these things is better than a ton of other medications we use for other medical issues. A lot of the problem, I guess, two problems. One is the stigma we talked about. People don't want to be on these because of the stigma. I hope that will disappear over time. And number two is access, what Brodie was just saying. But more and more GPs are getting comfortable with it. So if you or someone is in this world of substance use, it is a medical issue. There are amazing treatments for it. And if you are ready to reach out, then find somewhere or someone you can reach out to. It's just a lot of great work has been done in this world.
Some sobering statistics, demonstrate that there are more than 5 million Americans that struggle with opioid use disorder. And the majority of them, 75% of them or more, lack access to care, to deal with this. And this 5 million figure is a rough estimate, because there are a lot of undiagnosed opioid use disorder or, any other form of addiction. So I think that's very important. And what we know is that about 80,000 people in a year die from opioid overdose. there were some improvement from previous years, which were over 100,000 deaths, from opioid overdose in the U.S. But we're making some improvement, but still 80,000 deaths is way too many.
Yep.
And so I think, there are ways that we could improve. And I hope that listeners who are listening to this can have a better understanding of what is opioid, maybe shake a little bit of stigma around it, in terms of addiction, and then understand what is, accessible treatment if there's somebody who's having opioid overdose that could really be life-saving.
Yeah, that's great. I mean, I think my take home from this is, Narcan is a safe drug. If this is something like, I don't know, it should almost be like a household or like in your car type of medication, because you just never know, right? It's hard to actually say who's at risk for an opioid overdose because it's just so prevalent. Again, you talked about those accidental overdoses as well, right? But this should be on like every university campus, right?
Yeah.
You can argue anyone at home that's even prescribed opiates, even if it's after surgery and they're at home with it, right? Like it should almost be as a part of the prescription or the discharge to go home with it. Narcan is safe. There's no side effects to giving it, and it does save lives when you are able to give it within that critical time.
Then I think take home, I'm going to go right back to the beginning. Opioids are necessary in many situations, as long as you have the right guidance using them and the right healthcare practitioners. It's like any other medication. They are necessary sometimes. Every medication we use has side effects, and you just have to know what you're getting into, understand the risks and the benefits. And if you need them, you need them. If you don't want them.
Yeah, this is. I think this is. This was this was a really good topic.
Yeah.
I think everybody's really passionate about this topic because this really, it affects, patients of all ages, all socioeconomic demographics. This could affect, everyone that we know.
Yep. And I think what's really important is we clearly have no script. And that has been proven clearly in this episode more than ever before.
Just to summarize, we started with opiates. We went to fentanyl. We then transitioned to garden stones, switched to cartels, and now we're back up to saying we love you and thanks for listening.
We actually started with Center Island and then
local
memory. And who knows? Guys, I don't even know what podcast this is.
Yeah, Yeah, I mean, this is world-class journalism, very consistent, to the point.
Luckily we're not like at the Oscars. There's no red light telling us all to shut the fuck up.
Can't wait to see what actually stays in this episode.
Well, a lot of editing for Brodie to do.
Sorry, buddy.
All right, guys.
You picked this topic.
My bad. I will see you next week.
Well, so this was great. Thank you. Thank you, Brodie. Have a good night. Or have a good week.